Melanoma Matters is an educational resource, and the opinions we express are our own and do not reflect medical advice. If you have questions specific to your own situation, please contact your own clinician. This podcast may be available in both audio and visual, so please check your platform. Ready?
Yeah.
Hi, everybody. Welcome to Melanoma Matters. I'm James Larkin.
I'm Sapna Patel.
Okay, so today we're going to talk a little bit about cancer cachexia, and the reason for that actually is a recent article in NEJM, end of 2024, which I think is...
What's the name of that drug that we're going to talk about?
We don't really know how to pronounce it, if we're honest, do we? But we think it's Ponsegramab or similar, but we're still kind of slightly working on that. Yeah, there's a few candidate suggestions. Anyway, before we start that, I'm going to ask you, how did you prepare for this podcast?
Full disclosure, I have not prepared for it. You're trying to bait me into saying something else. Full disclosure, I have not prepared. How did you prepare for it?
I read the article. That's crazy, isn't it? Yeah, I read the article. Sorry?
So this is going to be mostly you. By the way, I read it when it came out in print. I told you the whole story of months back. There was somebody I was looking up, and he was mentioning, oh, great to see this cancer cachexia drug, and it had gone online in September. So I read it then read it when it came out in print, but that's more than a month. That's almost a month ago. So.
Yeah. I mean, I suppose by way of background, I think it's fair to say in melanoma, I don't know what you think, that cachexia for a lot of our patients isn't a major problem. At least I'm thinking about melanoma versus kidney cancer. It's a massive issue in kidney cancer, particularly when people have been on anti-VEGF treatments for long periods of time, because a lot of the patients are beginning to get sarcopenia and they just get that whole kind of cachectic look. And I think the kind of reality for a lot of our patients with melanoma, say if they're on a checkpoint inhibitor or something, we don't really see this very much. And then for the people who've got BRAF mutant melanoma with metastatic disease, I'm sure you and I and everybody's got lots of patients who've been on those treatments for years and years, and it doesn't feel to me, and I don't see in clinic actually, that cachexia is a really big problem. But I think if in the totality of cancers, and now I'm thinking about lung cancer, pancreatic cancer in particular, it's a really, really big issue. So I guess that's one of the reasons we thought this was interesting.
Yeah, do you think it also has to do with our types of therapy, that more cytotoxic chemotherapy-based tumors are going to be susceptible to a cachexia that's not the same as targeted or checkpoint inhibitor? You're seeing it in kidney, obviously, but...
Well, definitely. So it's going to be the disease, isn't it? And it's going to be, I think, to some extent, the treatment, which I suppose was what I was alluding to with kidney cancer. But yeah, one gets the feeling that cytotoxics and certainly anti-VEGF treatment, I'd hesitate a little bit to go beyond that, actually, in terms of treatments that can be associated with it. And I suppose the other thing might be for people who've got cancers that interfere, if you like, with the upper aerodigestive tract as well, then malnutrition's obviously going to be a problem either from the disease or sometimes from treatment, actually.
That makes a lot of sense, that the kind of the digestive tract involvement. But as you and I know, that melanoma can hit anywhere. So it's not that a metastatic pancreas patient or a metastatic lung cancer patient necessarily has metastases that are unlike what we might see in melanoma. We still get the liver involvement. We can get, obviously lung and bone and whatever. It's got to be some unique feature of the treatments that we're reaching for that then don't necessarily lead to as much cachexia, because it can't certainly just be the location of these cancers.
No, I'm sure it's multifactorial. And I think it's an area that, it says this in the editorial, that doctors have known about for 2,500 years, citing Hippocrates in the editorial. And we've all known about it the whole time. But I think it's only really started to get a lot of attention, shall we say, biologically in the relatively recent past, which is long overdue. I think we could all agree that, couldn't we? So we know cachexia is common in cancer, and we know it's a bad thing. Patients obviously feel awful most of the time. It may interfere with the efficacy of our treatments. People are susceptible to infections, thrombosis, all that kind of stuff. And so I guess the premise here is that there's a cytokine which is called GDF15, which stands for growth differentiation factor 15, is elevated in cancer cachexia. And in this trial, which is a phase 2 trial randomized on the back of a previous phase 1b, a monoclonal antibody targeting GD15 is being tested. And so what the authors have done, and this is Dr. Grauch and colleagues, so it's a multi-institutional effort. I think this is a Pfizer drug as well, just for the record. Ponsegramab, there I've tried again. I don't know if that was good or not. What you needed to have is an elevated serum GD15 level, so greater than equal to 1,500 picograms per milliliter in the serum. And there were basically 4 options, randomized 1 to 1 to 1 to 1. And you could either get 100, 200, or 400 milligrams of this drug or placebo, given subcutaneously every 4 weeks for 3 doses. And then the primary endpoint's quite cool, I think, which is change your baseline body weight at 3 months. Go on.
Yeah, hang on. That's interesting that it's a subcutaneous injection, right? Because in cachexia, we often think, and they define it here by weight loss predominantly. That's the eligibility is weight loss. And like you mentioned, this elevated GDF15 serum level. But, as we see anasarca or sarcopenia in these cancer cachexia patients, or maybe I should say it the other way, in patients with cancer cachexia, I would often think that, I guess they have, maybe I should rethink this. They have subcutaneous fatty tissue. What they're losing is protein and muscle mass. I think of a subcutaneous formulation needing the transit, that hyaluronidase portion, and I don't know what this one's adjuvantized with, but it needs something to help with delivery through that tissue to get systemic. And that's often going to be through your fatty tissue. And I don't necessarily know if I think of cachexia and adequate soft tissue as going together, but maybe what I should think is that cachexia and protein muscle mass don't go together.
Yeah, I mean, I think that's one of the issues. It's one of these things where I think we all kind of know what we think this is, but are there really adequate, widely accepted definitions? Maybe not at the moment. But I must admit, my sort of clinical gut feeling is exactly like yours, and I worry about subcutaneous injections in people who've got a lot of cachexia, or let's say subcutaneous edema as well, which they sort of will often go hand in hand.
Yeah.
Anyway, so I think that's a pretty important point. So anyway, 187 patients altogether. So sort of decent numbers, bearing in mind that there were 4 different options. 40% non-small cell lung cancer, 32% pancreatic cancer, 29% colorectal cancer. And I'm actually just reading from the abstract here because I think it's kind of all there in the abstract. So at 12 weeks, the patients in the Ponsegromab groups had significantly greater weight gain than the placebo group. And so the median between group difference was about 1.2 kilograms. So you need to help me out there with the US conversion, but that's going to come out, isn't it, around about 2.5 pounds, something like that, maybe slightly over that. In the 100 milligram group, 1.92 in the 200 milligrams group, and 2.81 in the 400 milligrams group, with quite wide kind of confidence intervals. They call them credibility intervals here, 95%. Yeah, exactly. So that's almost 3 kilograms, which is kind of 6 pounds or something like that over 3 months.
And this is, remind us how big this study was, how many in each of these groups? It's fairly
So
small.
187 divided by 4, basically. Yeah. So again, if you do the math on that, yeah, it's just over 45, 46, 47, something like that. So I think that's pretty striking, I have to say, particularly in the highest dose group. And of course, 3 kilograms depending on what your starting weight is. If you've got a really low starting weight, and there'll be some people who've got, I apologize for being in kilograms, but there'll be some people who are starting at 40, 45 kilograms, which is probably 90, 100 pounds, something like that. So in terms of a proportion of body weight, that's quite a lot. So I think that's quite striking. There were quite a few other secondary endpoints: appetite, symptoms from cachexia, measurement of physical activity, and safety. And so there was also improvement in a lot of those secondary outcomes, which is kind of tracking, if you like, the weight gain. So I'm actually, delighted, and I think it's telling, isn't it, that this was in NEJM, a sort of a relatively small dose ranging randomized study, with an editorial, and also with a sort of a science behind commentary as well.
By the way, did you and I decide this led to a drug approval, or it's just interesting? I can't remember if this is actually approved now.
I don't think there's an approval. Okay. I would imagine you might want a more definitive randomized trial at the dose that you're picking, I would have thought. Just in terms of safety, I don't think there were any concerns or issues really there at all. I think there were a few sort of injection site type reactions, a bit of diarrhea, some nausea, pyrexia. I think the problem with all of those things really is going to be difficult to disentangle them anyway from a group of patients who are inherently, unfortunately, quite sick. So I think it looked like it was relatively well tolerated. If you just look at figure 2 maybe as well, I mean, figure 1's a kind of, it's striking, but I suppose it doesn't really tell you much, because it's just really telling you what I've said already from the abstract. These nice histograms which are showing you that the body weight is going up with increasing dose, and of course going down with placebo. I mean, that's another thing to say here, right? These are people where, according to what we would do standard practice in the clinic at the moment, I don't think we've really got anything good for these patients, to be quite honest. And so guess what? They're losing weight. And even if you do things in clinic, maybe this is a slight digression to try and help with this, maybe steroids. I mean, I think in the old days, we sometimes used to use progestogens. We could even have a conversation about that. I think a lot of the time you're just going to cause weight gain with fluid rather than achieving what we want to achieve, which is obviously going to be lean body mass, I think. So, in the old days in kidney cancer, we used to use Provera for people who are and so the patient, big doses too. The patients always used to feel loads better, of course, but then they got quite a lot of weight gain and edema, and they all had quite a high DVT risk as well. And it's really interesting. When I started, this is 20 years ago, it would be regarded as what you would do if someone had not responded to cytokines with kidney cancer. You'd put them on progestogen, and then it just disappeared from practice when we had the first kind of randomized trial, of one of the newer agents. But so that's sort of confined to the past. The other thing I was just going to mention maybe is the subgroup analysis of the primary endpoint in the 400 milligrams group, which is figure 2. And if you look at that, there's a load of different things are being looked at. So type of cancer is one of them, serum GDF at screening by quartile, whether they'd had platinum before, BMI at randomization above or below 20, CRP to albumin ratio, and so on. And very clearly, small numbers, etc., all of those are to the right of the line, meaning that intervention's better than placebo. Like I said to you before, the thing I was really interested in, and I couldn't see it anywhere, is whether there's any sort of relationship between suppressing the serum GDF level and clinical outcomes. Because remembering that this is done in a group of patients with elevated serum GDF levels, and that you're giving different doses of the drug, I wonder if there's a relationship between the extent to which you can suppress serum GDF levels with this drug and the weight gain. And I'd be surprised if there weren't data on that, and maybe they're waiting for a follow-up, but I'd love to see that actually. Go on.
I was going to just check and see if it was in the supplemental. I mean, in this plain language summary, they talk about um, weight gain was unrelated to the elevation in baseline GDF, but they don't address your specific point in that plain language summary, which is what about the delta in GDF? Did that seem to correlate with benefit from this? Interestingly, the adverse events were highest in the placebo group. So
Yeah,
that's fascinating.
yeah,
The group with essentially no change in weight, like you said, highest in the 400 milligram. This is in line with Project Optimus, which is an FDA mission to sort of figure out your dosing in your randomized trial. So not necessarily doing the typical phase 1 3+3 to find an MTD, but actually optimizing the dose with bigger cohorts like this. So I think this addressed that Optimus criteria. Does not have an approval. You're right. Just this kind of phase 2. Be interesting to know what the randomized phase 3 would look like when this phase 2. This can happen when you do good randomized phase 2s. Is who's going to want to do the phase 3 when placebo didn't even do as well as 100 milligrams? Who then wants to randomize against 400? I think the other cool thing is that it's 3 doses and you're done. It's a subcutaneous injection every 4 weeks for 3 doses, a primary endpoint at 12 weeks, which is kind of interesting, right? Because depending on how they timed it, if they're calling it weeks 4, hopefully they're calling it week 0, 4, and 8, and then checking at week 12. But if you're calling it weeks, well, I guess that has to be how it is, because you wouldn't be able to check at week 12 and be getting an injection at week 12. So, but yeah, this is all kind of really interesting stuff. Let me just check the supplemental here.
yeah. But even that interests me. I mean, I can't help myself really, because I'm just thinking, well, look, you've got a treatment here that seems to be fairly well tolerated. There's a dose dependent effect from what we can see here at the moment. Then is that enough treatment, or might some patients benefit from more treatment? And it slightly gets back to the issue about the levels of the GDF-15, because let's say that you'd given 3 treatments or something like that, and whatever your target might be, and I don't know the answer to that, or why not do more treatment if you're not suppressing it, or at least ask that question.
Yeah, I think that's a good point. Let me just check the supplementary because it seems like something they might have put in there.
Yeah, so while you're doing that, another thing that's quite close to my heart, as you know, and I think it's raised either in the discussion or the editorial, is they had this exploratory endpoint, which is change in lumbar skeletal muscle index. So this really speaks to this whole point about it's all very well having weight gain, but what is that weight gain? And this is just a small paragraph actually, but in the 400 milligram group, the difference from placebo was just over 2 centimeters per square meter at week 12. Now, what does that mean? I do not know, honestly. The way they measure it, this is quite cool as well. Skeletal muscle area divided by the square of the height. So that actually is in supplemental. It says 16 and 17. I would just love to know how they measured skeletal muscle area. So maybe that's a snapshot on a CT of the lumbar. I know this is doable actually, because if you think about doing it with AI or something like that, it would be quite straightforward. You just need to train the computer program how to recognize skeletal muscle when you get a shot through the kind of lumbar area of the body. And again, that raises another point here, which is about nutrition, I think, and you and I talk about this quite a lot. And again, this is raised, I think, by the authors or the editorialist. So I don't think this should be seen in isolation. If you're giving someone a treatment like this, then I think thinking about nutrition and physical activity must be a part of that, because we all know very well that you're not really going to be able to build useful weight gain without the correct nutrition and without activity. And I think for me, the correct nutrition is going to be about protein, certainly, probably number one, as well as, I'm no dietitian, as well as having an appropriately balanced diet. Sorry, I think you're going to say.
No, it's all good. In the supplementary, this supplementary is dense. It's 55 pages long, but they do have a change from baseline for physical activity and gait endpoints. So that's something. It's not quite the same thing as the physical activity that we often think about, which is really muscle load and resistance training. But, obviously walking, and that would be interesting to look at. I'll peek at that. There is something on the sort of cachexia related diary, symptom diary. So that might be interesting to see what they're saying as far there. I don't see anything about nutrition specifically. It's about severity of appetite loss, but not necessarily like, could you tell that you increased your protein intake or anything like that? And I don't see, there is a portion of patients who died prior to week 12, just FYI. So there's that. Blood pressure numbers here. I don't see anything about, oh, interesting. I don't see anything about GDF levels that they
Yeah.
talking about on treatment GDF levels. Like you said, they could be saving that for another manuscript. There is a change in RECIST here. I'm just curious because in a future episode, you and I are going to talk about the Godfather trial, which is GDF15 inhibition for PD-1 resistance. So interesting to know if any of these patients generated a RECIST response.
So I think that's a fascinating question for checkpoint inhibitors in particular. I mean, a lot of these patients actually probably won't have been treated with checkpoint inhibitors. If you look at some of them will with lung cancer, I guess, but probably not much with pancreas, and I would imagine very few with colorectal cancer. But I'm not sure quite how well it's demonstrated, if you like, in the literature, but it sort of comes back to the immune competence of the patient, and we're giving them treatment with checkpoint inhibitors where one of the requirements really is to have some sort of level. So if you want to say maybe treatment like this may help to reconstitute the immune system, so if you already had an immune checkpoint inhibitor on board and it hadn't benefited you, it's a really striking question. Could you then be in a position to benefit just from general immune competence rather than any particular specific mechanism? Because that's obviously another question as well.
Yeah.
You're going to say, go on.
Well, it's hard to make heads or tails out of this RECIST table here. What is jumping out at me is there are not a lot. I mean, the majority of patients completed week 12 visit, but about anywhere between 14 to 16 patients per group did not make it to the week 12 visit. So in the placebo group, 45 patients, 32 made it to week 12. So 13 died off. That's about a quarter of patients. In the 400 milligram group, 50 patients, 34 made it to week 12. So 16 didn't make it there. It's about a third of that sample size. And in the 200 milligram group, only 7 patients didn't make it, but in the 100 milligram, another 14 didn't make it to week 12. That's pretty telling. Hard to know. I mean, they have it in here, what cancer these patients had, what therapy they had received prior. So you do know who got checkpoint inhibitor, et cetera. What you don't, I'm not sure I get a sense of is, did they take Ponsegromab alone or did they take Ponsegromab with their ongoing cancer therapy?
Yeah.
Regardless, it's a nice...
Yeah, well, I mean, that's it, isn't it? I mean, I think genuinely this is really, really exciting. A number of drug companies have got similar drugs and they're beginning to be tested. And, if it was me, I kind of think I'm seeing enough to even go for a randomized trial up front in a disease like pancreatic cancer, metastatic pancreatic cancer, where outcomes are really poor as things stand at the moment. There hasn't really been that much therapeutic. And, if I had a nasty pancreatic cancer and elevated serum GDF, I'd be happy to go into randomized trial, if you like, of standard of care treatment plus minus. And I think if they were able, get an efficacy benefit there, and I'm thinking in terms of cancer control now, not increase in weight gain, that would be incredible, actually. Yeah.
So let me ask a final question, unless there's anything else you think there is to say on this.
Ask away.
Okay. So as I look at this author list and I look that this study was done, I was looking, it's easier to read it on my PDF. So it looks like this was done through Duke, Edinburgh, OHSU, the Knight Cancer Institute there, Kyoto, Cedars in Los Angeles, Ottawa, Rochester.
Yeah, Kyoto, a few other places. Yeah.
Then I want to ask a question with a straight face. How do you feel about first and senior authorship being drug company authorship and not the investigators who did the work?
Well, I think it's going to come back to contribution first and foremost. It always should. Authorship should.
Okay.
Who's done what? Who's done what? But it is relatively unusual, to slightly answer your question, maybe, for people from industry and to be certainly both first and senior author. Very unusual indeed. Sometimes you might see someone from industry maybe sharing authorship, either first or senior, but I think it has to come back to contribution. I guess we're both academics, that you'd like to hope that when trials are being designed, they're being designed in conjunction with academics and other stakeholders, if you want to call it that. Not forgetting patients either, by the way, actually, when we're saying this. And in an ideal world, I think those who've contributed most should be the joint first and lead authors. So it's a little bit of a sitting on the fence answer, but I think you'll have got the gist of what I think.
Yeah, I appreciate that probably this didn't come from any investigator's lab, and it was a lot of negotiation between the FDA and the company to get this trial design right. As you said, 4 arms, 1 to 1 to 1 to 1. None of that was easy, which means there was a lot of pre-enrollment involvement from the company. But I do think, particularly as this moves on to a phase 3 and thereon, the patients and the investigators at these sites are doing a load of work, getting the data in, the analysis notwithstanding. I mean, as you were mentioning, checking GDF levels, CRP, all these things. But, I would love to see, I know this was a passion project for some of these investigators, and it would be nice to also make sure that they're getting recognition here. So,
Yeah, and my other point there is going to be that I think involvement with academia is really, really important for drug development. And there have been lots of examples where people have given advice, shall we say, and then it hasn't been taken. And now's not the time to list them out. And actually, they've ended up entire programs have been unsuccessful as a consequence of that. And I think the people are actually seeing the patients in the clinic and are thinking about the disease all the time. Frankly, how can they not contribute significant insights to the development? But I guess I don't really know any of the details here, and probably you don't really either.
well, I don't know the details of this particular manuscript and drug, but as you're saying what you're saying, that, academic input sometimes isn't followed, and then it can be, the beginning of the end of a product or a pipeline for a company. It's funny, in those instances, it does seem like the academics get their necks put out there as first and senior authors. Right? Because they're often the ones that have to do the presentation of the negative trial, or, do a postmortem on things, if you will. But anyway,
Yeah,
collaborate.
I'm just going to do a slight advert for an upcoming podcast as well on this subject, which we don't know when it's going to be. But today we saw again what I thought was a really exciting press release from Regeneron about adjuvant cemiplimab in high risk SCC. It's out in the public domain now, so I can say it. Hazard ratio 0.3 versus placebo. Really, really striking. I mean, yes, I think you would have predicted a positive trial, but to see that, I think that's a really striking level of benefit. So then the interesting question there for a future podcast, when we've got these data sets and these papers in front of us, is I think Merck did a similar trial with pembrolizumab, which is actually...
a finger, by the way?
Sorry, no, that's 2 together, by the way. I'm praying. I'm praying. Yeah. Good question though. So then Merck did a similar trial with Pembro, which was negative for the primary endpoint. So there's a really interesting discussion that we could have a little bit about why that happened in the future, and what those protocols look like. So I think the expression you use is put a pin in that one.
Put a pin in it. And just a quick question: have we seen an adjuvant melanoma trial with that hazard ratio?
No. Short answer is no. I mean, the closest to neoadjuvant, you should know that.
No, but Combi Nadina did very well, I should say. Yeah. Combi AD, did it not have an RFS hazard ratio of something? I don't know. We don't, again.
No, it's no. You're talking about 0.5, maybe slightly better, but not 0.3. I mean, like the number of trials that I can list off the top of my head with that type of level of benefit, a few and far between, almost all of them placebo controlled actually. So
Yeah,
Brim,
this almost gets to Bettina's point that she made on that podcast. What are we doing trials that have that huge a hazard ratio? Because it's almost as if we should have known better. The truth is, in non-melanoma skin and squame, we didn't know that adjuvant, PD-1, PD-L1 would be beneficial because the standard of care was surgery plus or minus adjuvant radiation. It wasn't
yeah,
clear that adjuvant PD-1 was going to be so massively beneficial. But,
yeah.
In the case that those trials were not phase 3s and they were phase 2s, how in good conscience could you follow those up? I think they were phase 3s. That's the point.
Yeah. For the record, I just thought of two. One of them is Brim 3 with a hazard ratio of around 0.25 for vemurafenib versus placebo. We've talked about that before. Maybe in a fact check we can pin the episode that we talked about that as well. But I think we all had a pretty good idea how active that drug was at the time versus placebo. And then the other one's kidney cancer trial, which is called Record 1, which was everolimus versus placebo back in the day. No. This is metastatic. And again, the hazard ratio is sort of 0.25, 0.3, something like that. Lancet, 2008, Bob Motzer was the first author. And that's actually probably, to get back to where we started, the trial that I think finished off Provera and hormones for people who'd got kidney cancer, because actually we could see that here's an active drug in everolimus. So maybe that's a nice way to end.
Perfect. Well, thanks for talking us through Ponsegramab for the treatment of cancer cachexia. John Groark. You said Groark. I said Groark.
Which one of us is right?
Yeah, we don't know. We need John Groark to come tell us.
And he could help us with the pronunciation of the drug as well.
Ponsegramab. This is the December 19th, 20th edition of NEJM. 2020.
Yeah, 19th/26th. Yeah, exactly.
Oh, yeah,
NEJM.
Sorry, I covered it up. This was
yeah.
So
very good.
Well done. Congratulations to the company, to the investigators.
Yep, great effort. Look forward to seeing more.
All right.
Take care.
Hi, everybody. We're doing a fact check for for Ponsegramab.
Before we do, hang on. Where are you? You got to say where you are. It's more fun.
Oh, I'm from Tampa Bay, Florida. Society of Surgical Oncology with our colleagues here. I mean, by the time this gets to air, who knows? But yeah, I'm in Florida. Where are you?
March 25. I'm at home. Wimbledon. WFH, as we say. Which doesn't happen often. But Ponsegramab, what are you going to say about that?
Well, so in the episode we were talking about, this is about cancer cachexia, we were both taken by the fact that it was essentially like a phase 1/2b that landed in New England Journal of Medicine, but for good reason, because at that 400 milligram dose, the weight gain in these patients seemed meaningful. Oh, there is one other thing. I don't know if you have access to the article very easily. We did not do a good job describing any baseline demographics of these patients, and maybe reading table 1 would be a good idea. We'll do another check on this. Because I'm having a hard time even understanding which patient population this was, just listening back to it. And then what, you and I both guessed what would be, you said, sorry for using so much kilograms, but these are probably 45 kilo patients, right? But that's probably in table 1, the baseline weight and everything. Do you know what I mean? You talked about progestins. It used to be kind of I don't know if mainstay is the right word, but it was something you would gravitate towards for the treatment of cachexia. And maybe I thought you could give some historical context. You did mention that just sort of stopped once there was more effective therapy.
Yeah, so I suppose 20 years ago and more in kidney cancer, the only sort of mainstream treatment was cytokines, either high-dose interleukin 2 or interferon, both of which fairly toxic and both of which only really worked in people with a sort of particular disease biology, so low volume lung mets, good performance status, and so on and so forth. And so then the vast majority of patients in the clinic with kidney cancer, then as now, don't fit the bill for that. So cytokines are really only suitable for a pretty small number of patients. And the only other options really there, people had spent decades probably doing trials of various other things, including cytotoxic chemotherapy in the very early days, none of which really worked. So sometimes in patients who weren't suitable for either cytokines or trials, really it was best supportive care. And so for quite a lot of those patients, we used to use progesterones in quite high doses, which would stimulate appetite, make people feel better, improve energy levels sometimes. But on the downside, they'd gain weight, and quite often it was fluid, edema, and sometimes people would get DVTs. And so even though we didn't particularly regard it as an active anti-cancer therapy, I think that in the really old literature, there may have been the odd bit of efficacy reported, but I'm not sure it may have even preceded cross-sectional imaging, actually. So I'm a bit uncertain about that in my own mind. But anyway, the point is that when the kind of clearly active drugs came along, which benefited a higher proportion of patients in the clinic, so this is anti-VEGF drugs, so this would have been actually the original bevacizumab single agent randomized trial in NEJM, which I think Jim Yang is the lead author of that, 2003. That's just off the top of my head. But anyway, that was the first evidence of anti-VEGF treatment, I think, in any cancer having efficacy, and the first evidence in kidney cancer. And then sunitinib and sorafenib came along 2, 3, 4 years later. And then after that, everolimus came along, which is an mTOR inhibitor, as a subsequent line of treatment. And then just in clinical practice, progesterones just seemed to drop away because we had sort of potentially active treatment. So I guess it's a bit of a footnote, really, of how we used to practice in kidney cancer when there weren't really active treatments around. But to get back to the Ponsegramab, I mean, if that could be an adjunct to treatments in upper GI malignancy or any GI malignancy, pancreatic cancer in particular, where people are putting on weight and it deals with cachexia, and there's a load of unanswered questions here. I think, anyway, and I don't know if we said it in the podcast, this could be a really major area of therapeutic development and benefit to patients as well, actually.
So what I was going to pick up on is I would actually love to see this developed more, because if it actually turns out to be an active therapeutic that we can use for this symptom, we talked about that we don't see a lot of cachexia and melanoma. I do agree with that. But we do see the sarcopenia. We do see people's body composition change, whether that's lack of motivation or just like, they're in the throes of illness, we're inflaming them, all the things happen. I would like to use this in almost a pre-cachexia mode, like preconditioning. Let's get them on this. It's an injection. Let's get them on this, get their weight kind of up with real protein mass. We'd have to really focus on that protein and then muscle use. And anyway, it could be really interesting for the field. Just to kind of pick up on that. So you gave us that historical.
I was just going to say Pfizer will be being swamped by requests from oncologists, including surgical oncologists, to the point that you just raised. I mean, imagine if you could actually have a treatment that for a few weeks preoperatively could get people into bed. Yeah. And I'm sure there are dozens, maybe even hundreds of different things that they could do. And inevitably, in terms of a commercial development pathway, you can imagine they'll pick a few. It'll be interesting to see, I think, for investigators like us and colleagues around the world, whether we can convince them and other companies to do academic trials, because there's just so many things we can do. Sorry, go on.
I mean, through SWOG and many others, I feel like we definitely would have a role to do this. Did you just know that was Pfizer? Did you remember it? That's a good memory.
Remember what? That it was
That it was.
Pfizer?
Mhm.
Yeah, because if you looked at the authorship, I don't know if we talked about this, that it was almost exclusively, if not exclusively, Pfizer employees, certainly in lead and senior author roles, which doesn't actually happen that much. That's one thing to say. And I can't remember if we talked about it or not.
I think we did.
But
I think we fell asleep listening to
I
it,
think,
which is not an indication of the
sorry.
caliber of the cast.
And then I've got a few colleagues actually I've talked to about that subsequently as well, just in relevant disease areas, to say that, did you see this? Because if you didn't, you need to kind of get on it straight away.
You also, as a joke, tried to tell one of your junior trainees how we thought it was pronounced, and you made him Google it from a work phone. Okay, side note or related note. I was looking at NCCN guidelines because there is a little bit of line item in the supportive care guidelines on cancer cachexia. It's not fantastic. It basically says the workup is as you would assume. You screen for conditions like xerostomia, dysgeusia, dental issues, intractable hiccups, mucositis, candidiasis, early satiety, if gastroparesis, trimetoclopramide, nausea, vomiting, dyspnea, constipation, etc., etc. Don't forget the endocrine causes of cachexia. Assess complexities related to access to food, social determinants of health, and then interventions. Oof, this is not easy. It basically doesn't have like a go-to drug therapy. Counsel patients and family about benefits, risks, e.g. thrombosis, and options for pharmacologic management of cachexia. So this tells me that the pharmacologic management is still relying on those old progestins, as you mentioned. So even our national guidelines here don't really have anything more modern than what you were describing from 2 decades ago for the treatment of this. Yet we know a significant portion of cancer patients, maybe not always the ones we treat, but a significant portion are going through this. So there could be a real use here, I think, developing therapies for this space, but also for that preconditioning space.
Okay.
Good?
So we're good.
Okay. Well, thanks for this fact check on Ponsegromab.